مرحب بك يا بابا.
السلام عليكم مروان.
عليكم السلام ورحمة. الصورة واضحة.
كويسين؟ الصورة واضحة
الحمد
مش صح؟ صوت واضح؟
لله.
شغالين من المكتب بتاع سوزان.
الفرونتير شايفة الصورة ورا.
عشان شنو؟ عشان تكون كوايتر، لأنه في
اوكي.
بقى كانت شوية الناس لما يخشوا يمرقوا عندك هناك بيكون شنو؟ في حركة يعني هسي كده كده يكون very quiet.
اوكي.
هو باش 25 ولا باش 27 ولا كده؟
في 25 في 27
كويس.
في الاثنين. اي.
هسي هم معاي؟
اي كاتبين.
طيب نحن حقيقة قبل ما نبدأ الفترة دايرين نقول للناس 27 الكورس بتاع التروبيكال اللي درسناه جزء منه كبير باراسايتولوجي، عشان كده يعني ريليتد للليكتشرز اللي احنا اديناها about parasitology، لانه when I talk about a disease I usually cover parasitology, entomology, clinical and treatment. This is the most applied form of parasitology, these tropical diseases, because most of the tropical diseases are of tropical nature and parasitological nature. So that is something which they should care for and revise these lectures, which is going to be uh, of importance. Arwa will work on getting it on the YouTube. Okay, now it's 11 o'clock. I would like to welcome you yet to another lecture on infectious and tropical diseases. The disease we are going to discuss today is the disease of the century, of the last century. It has really ripped the whole globe and have caused a lot of mortality and morbidity. And it's a social disease, social family disease, which has greatly affected the world in many, many ways and have changed and influenced our understanding about a lot of virological consequences, immunity of the human body, the social impact of disease, and the political impact of diseases. So it was 1981 when 5 cases of pneumocystis carinii pneumonia were diagnosed in LA, Los Angeles, in the USA. These were homosexual patients, who had very severe pneumonia by pneumocystis carinii, and it really struck the physicians that their immunity is so depressed that they succumbing to this opportunistic infection. However, very soon, another 5 or 6 cases appeared in New York, and these are cases with Kaposi sarcoma. This, up to that time, has been a rare malignancy on the skin, but it was very obvious that this is something which is new. People were trying to link it, and very funny reasons of this disease has been postulated by case comparison and so on. But then very rapidly it occurred in many other cities in USA, and then it appeared in Haiti. Haitians have developed some same symptoms, and people could trace the epidemiological origin of this disease to a meeting or to a party, an annual party of homosexuals in Los Angeles. Okay, they usually meet annually, and they will have what I would call a free seating party that any partner could join the other whoever he wants, So that was like a messy business of a party. And many of those who developed these symptoms have attended that party. Anyway, but soon after, in Uganda, cases of very severe diarrhea, very wasted persons called slim disease, and these people thought it is it is similar to what they are seeing there because loss of weight, fever, malaise, prostration, weakness, uh, neuropathy, macular papular rash were common in these patients. However, this disease now I'm talking about is AIDS, HIV/AIDS, human immunodeficiency virus. HIV/AIDS is acquired immunodeficiency, and it is often called HIV/AIDS because acquired immunodeficiency could be due to a lot of other conditions, like if you have certain malignancies, it will depress the immunity. Drugs can depress the immunity, especially corticosteroids and cytotoxic drugs. So it's to label the AIDS or acquired immunodeficiency, we put HIV/AIDS, meaning that it is caused by HIV. Anyway, this disease was not recognized by to be the causative organism except in 1983, and at that time, mother to child infection has been described, and that was a landmark because now it is not it's not the patient who is carrying the virus. Up to now, up to that time, it was not known to be virus, but that who's carrying the disease. But mothers can pass it to their babies. So we know more about that later on. But in 1983, good research at two centers, Pasteur Institute in Paris and NIH in USA, Bethesda, Washington, discovered that this is due to a retrovirus. But before it was discovered to be retrovirus, the disease really clustered in homosexuals clustered in homosexual. This is why it was called at that time GRID, which is gay related immunodeficiency syndrome. GRID, gay related immunodeficiency syndrome. So it's you can appreciate the stigma which is being at that time associated with homosexuals. So the disease for up to from 81 to 83, there were uncertainty, fear, stigma, and patients with this disease, immunosuppression, were discriminated against. They were beaten, they were casted by stones, they were unlawfully dismissed from their work, nobody is eating with them. Those who are renting houses, they were really expelled out of the houses. So there were fear about it. I do remember that the first case, which was diagnosed in Soba Hospital in Khartoum, uh, the nurses knew about the case, so they went into strike for the case to be taken somewhere else. And they said that they were striking. They gathered in the gardens, around the hospital, and they refused to work because they could not, or they don't want to have nurse such a patient. So that was the social impact of this disease. Later on, it was discovered to be it's a virus, and it is a retrovirus, and this is shows the robust science which followed this virus. It's a rocket stage science, which is a story of success, I think. 81, the first case, 83, the discovery of the virus, and 85, people started having treatment for the disease. Up to that level, from 81 to 85, the disease is a death penalty. If somebody is being diagnosed as AIDS, then that is the death penalty. Just wait to see his fate as death. And indeed, in certain southern African countries, which is still very prevalent in these countries, the disease have reduced the lifespan of individuals to 34 years. So young people, the mass destruction of people. So in 1985, what we call antiretroviral therapy was discovered. And after the discovery of the retrovirus, which is the cause of AIDS, two things happened. Number one, we knew what the viral looked like, and that has helped in setting diagnoses because up to that time, no laboratory diagnosis could be made, it's only clinical. Secondly, we knew what the virus looked like to start developing drugs which will kill the virus. So it's a real piece of science, of robust science, that is helping, which helped the diagnosis. The early on, the diagnosis was put on ELISA, and the ELISA has its limitation, but then there is Western blot, and this is more accurate. Now we have more rapid tests, uh, more efficient and very accurate tests. And in 1902, the rapid HIV kits were introduced. Rapid HIV kits were introduced, and these are of 99% accuracy. Within 20 minutes, it will give you the result. So a lot of ethical problems have risen, ethical questions have risen. A lot of pathogenesis has been described very well. A lot of marital relationship has been reconstructed because there is a question. If somebody has AIDS, what happens to his partner? Are they willing? Do they disclose that they have AIDS and continue marriage, or they hide it, and then there is a chance of giving it to the partner? So it's that was where the question, and now the question of who to be tested, and is it voluntary to be tested, or you have to consent? Do we have the right to force everybody to be tested for HIV, or they have to consent? And up to now, it's the situation is they have to consent to testing. You cannot force anybody to test in HIV/AIDS unless he is in the hospital when you are thinking of diagnosing HIV/AIDS. So there is a lot of social complexity to this disease. More so, it has put certain group of people in a direction of under for the focus, but the gay, homosexuals, protested, and they cried for AIDS to be human rights. And as you know, that now the homosexuals are getting their way in the world, and nobody now talk about a disease related to gay or homosexuals. Okay, up to this time, up to date, I reckon there is 84 HIV, 84 million who have been infected by HIV. Out of those, 40 million are dead. So it's almost 50%. But this includes the early area, the early years of the disease before the ART, which is antiretroviral therapy, antiretroviral therapy. So in 2021, there are 1.5 million new cases. From that time to 2021, 1.5 million new cases in the world, and 650, just almost half, were dead with HIV. So, although there is a drug, the drug has changed our understanding, and the prognosis has been much improved. Nowadays, we are standing on the following position. AIDS is a viral disease which can be contracted and can be disseminated to others, person to person, or it can really be, hit hard by drugs. So what do the drugs do? The drugs, up to now, they suppress the viral replication. They suppress the viral replication, but they are not cure for the HIV/AIDS. So it's not a cure, and up to now we don't have a vaccine. We are depending on the antiretroviral therapy to suppress the virus. So the virus did not disappear; it is there, and as long as the patient is taking the drug, then the viral load will be decreased to such a level that the patient symptoms abate. They don't have symptoms, but the virus is there, so they can communicate the virus to others. So it is like hypertension. As long as you take the drugs, the blood pressure will be normal. So it is changing from an acute death causing disease to a disease which is a long chronic disease which can be curtailed or suppressed by the antiretroviral therapy. Okay, so something about the virus itself. Okay, if Arwa can show us a picture of the virus, if it is there. The virus is an RNA virus. Okay, it's an RNA virus which is have four enzymes. I don't know if the picture is coming or not. Okay, it contains four enzymes. These are transcriptase, reverse transcriptase enzyme, reverse transcriptase enzyme, protease enzyme, and integrase enzymes. I'll just spell them. The first enzyme is reverse transcriptase enzyme, and then we have protease enzyme, and then we have integrase enzyme. Emphasizing these enzymes because the drugs are driven to inhibit these enzymes. So if you inhibit the enzymes, then you are going to get the killing of the virus. They are going to kill the virus. So it's important to see the virus picture or diagram, and in the center there is two identical isomer RNA dimer, which is the genetic part of the virus, and it has an envelope. It's an enveloped virus RNA with a genetic part, which is in the center. Okay, two of them identical dimer, and enzymes, which is reverse transcriptase enzyme, protease enzyme, and integrase enzyme. So these enzymes are very essential to remember when we are talking about drugs. Okay, what are the chances? There is some trickiness about this virus because when it gets into the body, it's a fight. It's a fight. It's a battle between the virus and the immune system. The greatest blessing which we had in this world and God has given us is the immunity, immune response. We have seen in previous lectures how the immune response can curtail and can inhibit the appearance of malaria, of filariasis. Many of these parasites, they go in, but they are being kept at bay. They don't show symptoms. So it is the immunity which is driving us. Immunity is driving us to health. So the whole thing is dependent on the immunity. So I don't know if we're going to have the picture of the virus because it will help having uh, the the conception of the virus. But somebody asked, what is the chance of somebody getting the virus, contract the virus or the infection if he has sexual intercourse? We know now there are ways of getting the virus. First, people thought when the first cases came, they thought this is just restricted to homosexual. But very soon, patients reporting, women reporting from intercoursing with patients or males who have the AIDS, they started developing HIV/AIDS, and that was a very strong evidence that it's a heterosexual transmitted disease. Secondly, in 1983, as you said, babies born to ladies who have HIV has developed HIV. So these are three routes now. The homosexual through anal intercourse, the heterosexual through vaginal intercourse, and then blood transfusion, obviously, is another major one, giving blood or blood products like serum, whatever, or even pack cells when you give severely anemic patients. These, whatever the component of the blood, then HIV can be carried there. Okay, and then the state of affair is what are the other fluids and secretions of the body. Okay, we know now that amniotic fluid, if you are delivering an HIV patient, amniotic fluid comes into the doctor's or the midwife's hands. Amniotic fluid is something which can carry the virus. Pleural fluid can carry the virus, and pericardial fluid can carry the virus. But the one which does not carry, and that really made a lot of hustle and fussle during the early days about saliva. Saliva does not, so kissing is not a way of transmitting the virus. The other thing is mosquito. Many people thought that mosquito can transmit the virus, but now it's very clear that it doesn't. Maybe the amount taken up is or injected is small, whatever, but that is now proven. Urine does not take the virus. Feces does not take the virus. I'm saying this because early on, patients who go to the toilet, for the siphon toilet, people will not go up in that toilet because they fear that the virus may be hanging on. But vaginal fluid is very clear that it can contain the virus or carry the virus, transmit the virus. Seminal fluid is also another form. So heterosexual, homosexual, transmission from mother to child, then these are the roots. So what are the chances of somebody mating or intercoursing with a patient who has the virus? What is the chances? The chances as it's calculated if a homosexual anal intercourse, if the patient or if the individual is receptive, that is the one below is receptive, then the chance is 1 to 72. So if the receptive uh, receives or intercourse with a patient who is positive, then the receptive will have a chance of 172. If if the male is insertive, that is the one who inserts, then the chances is 1 to 900. Okay, so that's for gay. However, for heterosexual, the receptive, that is the female, it have a chance of 1 to 1,250. So they have one chance to 1,250. So by statistics, that is to say, if they have 1,250 chance intercourse, then they get one. The chance is one. But that doesn't mean if you don't have one sexual intercourse, you will not get it unless you have 1,250. You can catch in the second, third, fourth, but that is statistics. It just shows what is the probability. What is the probability? If you are insertive, like male intercoursing with a female, then the chances is less. It's 1 to 2,500. So that will give you just a rough picture about the probability. And it's often said that if you have a few intercourses, it may not be the case. So why are homosexuals more prone to HIV? Okay, if the male is the insertive, if the male is inserting in a female, if a female in a male, in a male, then he ejaculates within the sigmoid, in the rectum. Then it is said that this ejection can affect the mucosa and causes ulceration. Wherever you have ulcers, then you have blood mixing. So the semen may mix with blood very rapidly, and the chances are high. This is because the colonic mucosa is columnar mucosa, is columnar and very frail and fragile. And unlike the vagina, which is squamous and it can bear the pressure and can bear the ejaculation. So that is the case of probabilities. The virus attacks the immunity. How does it do that? Okay, we know the cellular immunity, humoral immunity, these are the antibodies which are formed against a parasite, but we have cellular immunity, and these are the T lymphocytes, T cells. On these immune cells, the lymphocytes, there is a molecule or a protein or a receptor, which is on the top of the lymphocyte cell. Okay, and this is called CD4. CD4. It's a molecule. Okay, so the lymphocyte is marked by a molecule, and you have CD8. CD4 is the one which is being attacked. The lymphocyte and the macrophage, which carries the CD4 is the one which is attacked by the virus. What happens? It penetrates through CD4, it damages the CD4 molecule, attaches to it, and then penetrates in the cell to act on it. What will happen? It will multiply by its enzymes which are there. Secondly, it hijack the protein synthesis of the cells. They attach themselves to the chromosome DNA chromosomes, and then they hijack, and then they eat out the protein which is produced by the cells, and the cell dies. If the cell dies, then the immunity will be affected. So the patient will be cellular immunity deprived, and this is what calls for the opportunistic infections around. The other tricky thing about the HIV is that after the infection, you could have what is we call seroconversion syndrome. Seroconversion. That is the first time when uh, the patient is converted into a positive case. So the seroconversion can occur a few weeks after the infection. It lasts again a few weeks, and then it stops. The picture of that is it remains with minor symptoms, maybe not noticed, but the with lymphadenopathy. But then there is a very long asymptomatic period, very long asymptomatic period. So it's very tricky because at that time the virus is not hidden. It's not hidden. It's not latent. It's there, but it is fighting. The body is fighting that virus. So this is a critical period. The asymptomatic period can go on for up to 8 to 10 years. So the virus could be there. The body is fighting. And this is why I said, the immune system is a blessing from God, that they fight and fight. At the end of the day, they succumb. The immune system succumb to the virus, and then the virus gets the upper hand. So you can talk about 3 stages in the clinical picture of HIV. The first is days to weeks from the infection, and not all people develop it, but around about 40 to 90% of the people develop it. They develop what we call acute HIV, or acute HIV infection, or acute seroconversion. Acute seroconversion. The symptoms of this syndrome is fever, fatigue, myalgia, pharyngitis, okay, and papular, maybe seborrheic rash. It can be purpuric rash, okay, ulcers in the mouth, genital, and lymphadenopathy. The one which will persist is the lymphadenopathy. Very rarely you can have neurological symptoms like Guillain-Barré syndrome. It tricks the nerves for peripheral neuropathy and meningoencephalitis or encephalitis. But this disease is self-limiting. Self-limiting. So it's self-limiting, but if you diagnose the patient at this stage, now the WHO recommendation is to treat. The general regulation, the general guidelines is you should treat as soon as diagnosis is being made. Okay? To the extent that there are prerequisites to the drugs like investigations, baseline investigations of urea, enzymes, and so on, you should not wait. Once you take the blood, you should start treatment, because very much on prognosis depend on the early start of treatment. So that is stage one. We go back to stage one, which is the symptoms, acute HIV symptoms, and this is what we call seroconversion syndrome, the seroconversion of HIV. seroconversion. The second, which occurs, as I said, between 8 to 10 years, and this is what we call the symptomatic. The CD4 is a marker. The CD4, we can count the CD4, and it's a marker. The CD4 usually is between 400 to 1,500. Okay, this is important. When you go below 400, there are certain symptoms, but if you go below 200 cells which carry the CD4 per millimeter, if you go below 200, then opportunistic infection and full-blown picture of HIV/AIDS is there. Okay, so we measure the CD4, and the other indicator is what we call viral load. Viral load. Okay, now we can count, we can find the viral load or the CD4, which it tell you the advanced what is the state of HIV/AIDS, and if you go below 200 CD4 cells, sorry, CD4 cells, then you will have the full picture. So, what is the symptomatic HIV? We have the acute, which is the seroconversion. Then you have the asymptomatic period, okay, where the virus is fighting and symptoms are not there. And then you have the full-blown picture of symptomatic HIV. Okay, what are the early indicators? Because the first may be may not be seen, okay, or passed unnoticed because it can simulate any other disease, okay? It can simulate another influenza, viral infections, other viral infections. So the first seroconversion syndrome may not be very florid and it can pass. The asymptomatic, obviously, there is no symptoms apart from lymphadenopathy, which can be passed as anything. But then we have the symptomatic HIV, okay, where the disease appears with all its symptoms. What are these symptoms? The symptoms vary. You may have a rash, which is simple as that. This is papular pruritic rash, okay, and then you have marked weight loss. Marked weight loss. You can have diarrhea. You can have diarrhea, or you can have neuropathy, okay? But the patient is very ill, his loss of weight, very marked loss of weight, and then his ability, for to combat infections like influenza, flu, or other viruses is very weak. So the least viral or other bacterial infection can show itself very clear because the immunity is not there. And then this is the period of OIS, which is opportunistic infection. The prognosis of AIDS and the mortality of AIDS is very much related to the opportunistic infection. So one of the major uh, drive to death is you have opportunistic infections. So, and uh, malignancies. Malignancies can also occur in the very severe cases. So, what are the opportunistic infections? We talk about tuberculosis, human or atypical tuberculosis, and many patients who succumb because of tuberculosis. This is why HIV/AIDS is now very much linked to tuberculosis, and this is why you remember in one of the lectures I talked about Global Fund. The Global Fund is an international fund which supports three major diseases, which are HIV/AIDS, tuberculosis, and malaria. Okay, so tuberculosis is one of the major determinants of health in HIV. Then you have toxoplasmosis, toxocara, you have strongyloides, you have cryptococci, you have pneumocystis carinii, all the fungal infections which are, is not seen in competent immune patient, then they appear in such patients, leading to death. And the other thing is certain tumors, particularly lymphomas. Lymphoma, which is the one which is associated with EB, Epstein-Barr virus. And you remember when we were talking about malaria, we talked about a lymphoma EB-related virus, EB-related virus lymphoma, Burkitt's lymphoma in children, and it has a belt of the malaria endemicity. That is where it appears. So this is almost the same lymphoma, EB-related lymphoma, and Kaposi sarcoma. Kaposi sarcoma, as I said earlier, when it was described in these patients, were rare. In skin shows very characteristic picture, but then these are the malignancy which can appear in HIV/AIDS. There is an appearance of abnormal lymphocytes in the blood. This is also something which relates and what points to the HIV/AIDS. So that is the clinical picture. So when can we diagnose? What is the indicators? The indicators is, it's often people hide because nobody would like to say that he has HIV. Okay, so the symptoms has to be, brought up. And these are, if you just look into what happens if the immune system is depressed, then you get some vague symptoms, some unrelated symptoms, fatigability, something very specific, fever, rashes, lymphadenopathy is there, loss of weight, which is remarkable, diarrhea, abdominal diarrhea, and the rest. So it's something which you have to keep in mind, which you have to pick up. And luckily, those students who are studying in Sri Hindu Mandal and Temeke hospitals in Tanzania, they have a separate department and separate specialists, consultants on HIV tuberculosis. So they have a good chance of seeing quite a number of patients with HIV, TB, and this is important. HIV/AIDS has taught us a lot about the immunity of the human, a lot about the immunity of the humans. So it's something which is borne in mind. Obviously, when we talk about control, before I go into the diagnosis and treatment, the control, this is a social problem. It's very complex because it touches on one of the human activities, sex, which is very important to people. It touches on that. It limits somebody's ability to do that. And there is a lot of psychological and social problems and complexities around AIDS. Some are very vindictive, they hide the HIV/AIDS and they go around distributing it or infecting others, and they see that this is, it's been done on them, and now they are revenging. So that's an extreme, okay? The other extreme is some people who are very depressed with HIV/AIDS, and they keep away, from life. Then there are a lot of socially active societies which are supporting the patients with HIV/AIDS, and these are civil societies which works on psychology of the patients, works on some psychiatric effect of these diseases, can be frank psychotic, and then it works on education. What is the education? The use of condom when you are practicing sex, and then the care of the homosexual, how they practice safe sex, with condoms, whatever. Because this is, it's with us, we cannot deny it. But if you really want to control the disease, you have to address it in a scientific way. Since it is there, it's has to be looked into. Then we have the overall prognosis. The major turning point in the epidemiology of AIDS is after the introduction of antiretroviral therapy, because that has changed the whole picture, and it has really um, shown that by drugs you can influence the epidemiology of the disease. So now people don't die from HIV/AIDS as far as they are receiving their drugs, except if there is a gap between it, and then opportunistic, severe opportunistic catches the patient, then the response will be very bad. Okay, so it's a virus which is very very severe, which is affecting the whole body and affecting the whole community. You have to be very clear about it. So, what are the way forward? The way forward is diagnosis. Okay, one of the factors which will influence the epidemiology is early pickup of patients. If you diagnose patients very early, okay, you can have treatment, start treatment very early, and as I said, now the WHO recommendation is to start treatment as soon, even in the conversion syndrome or conventional state. Okay, then you go with antiretroviral therapy. So that's number one, because this will reduce the viral load, which improve CD4, and then the patient will, the transmissibility of the viruses will be less. So that will influence the epidemiology. Apart from the effect on the human individual patient, it affects the whole epidemiology and transmission of the disease. Okay, so the antiretroviral. Secondly, it poses a problem and a challenge, because now you are reducing the viral load, but you are not eliminating the virus. So the antiretroviral will push down the viral load, but still the patient can infect others. And this poses the problem, the difficult question of how can we deal with these people now are fit, are, they can enjoy life, they can marry, they can have sex, So what is the marital position and what is the social position of these patients? Because they can transmit the disease. They themselves are very, very healthy in a sense that they do what other people do, but they are still carrying the virus. So that is the question which need to be discussed. Okay, so the antiretroviral therapy has changed the life. Now it's not a death penalty, a death certificate. It curtails the infection. So these people are now working within us and as part of the community and need to be addressed very carefully. Okay, the fluids which I think need to be remembered that they can transmit or transfer the virus needs to be thought of, because if you are in the delivery room, you have to be careful about the amniotic fluid. Okay, if you are a surgeon, there are certain precautions which you have to operate on them, especially pregnant ladies who have a cesarean section. Surgeons can expose themselves to HIV virus, So should be precautions. So, especially surgeons who are dealing with a lot of blood, obviously, like cesarean sections or whatever, then they can mix. So the puncturing or needle, needle going into the body can transmit AIDS. Okay, so it's as medical professionals, we have to look after ourselves. So amniotic fluid, any blood component, full blood or part of the blood or blood component, then that will take you to the infection. Injections is very important. This is why we don't use injection or needles which has been used. We are very careful when taking the blood. We don't get injected by the needle which we have taken the blood with, because this may be infected. Obviously, blood transfusion is another big issue. And now, luckily, the WHO is providing kits for HIV testing before donation. You have to test the patient as HIV negative before taking the blood. Then we have fluids, obviously the fluids which relates to sexual intercourse, like seminal fluid, like vaginal fluid. Okay, these are the ones which one has to think about. Even if you go to a barber, halal, then if he uses for the males, okay, obviously, who uses certain techniques or razors, which are not sterilized, then this is another way of uh, contracting the infection. So remember that you don't want to mix your blood with the blood of any patient, be it HIV or otherwise. So whatever that is, you can. This is why it appears early on, before we know that it is in the blood. The group of hemophiliacs who have been positive is very high. And other people who receive blood regularly, or any hematological disease or cancer disease, then they are likely to get blood which is not tested, and this is has to be borne in mind. But saliva, vomitus, feces, urine, these do not transmit the virus. I would like to say that we have to be scientific in our thinking, okay? And if we say this does not, there is good evidence based that these secretions do not transmit. So it's easy said, don't touch the patient, and don't eat with him, don't even greet him by hand. These are not scientifically based precautions. So it's only the blood components, vaginal fluid, seminal fluid, pleural fluid, pericardial fluid, this amniotic fluid, these are the ones which can transmit the infection. So it's the diagnosis now. I said it used to be ELISA and Western blot. Now we have kits, which is very easy, 99% accuracy, and it can be used at the peripheral health system, peripheral health centers, or peripheral where nurses are there or medical assistant. Testing will depend very much on the acceptance of the patient. Okay, I would like just to end with highlight of the different stages with WHO. The WHO now is talking about clinical staging, and this came into 007, and they have 4 stages. Stage 1 is the persistent generalized lymphadenopathy, which is what we call the seroconversion. Then the clinical symptoms is obviously weight loss, and then the rash, uh, the mucocutaneous lesions, angular stomatitis, herpes. Herpes zoster, herpes simplex is very common. And then repeated recurrent urinary tract infection. This is the clinical stage, which is showing now partial opportunity, the opportunistic infections. Okay, that's stage 2. The stage 3 is severe. Stage 3 is severe, then weight loss is more than 10%. Okay, then chronic diarrhea, which cannot be explained by cultures or by anything, oral candidiasis, and then pulmonary tuberculosis, which we said is very prevalent in patients with HIV. Then bacterial infections, it will be normal patients who they have pneumonia, for instance, then they can come out of it, especially if helped by antibiotics, but these patients will have the pneumonia being very severe. And then we have ulcers in the mouth, what we severe ulcers, necrotizing ulcers, ulcers not like the aphthous ulcer, which many people have, but these are deep ulcer, what we call necrotizing ulcer. And then we have severe anemia, and chronic thrombocytopenia. That is stage 3. Stage 4 is the florid HIV, which is what we call the wasting HIV, wasting disease or wasting syndrome. Then now you have central nervous system affection like meningoencephalitis, and you have infections, very severe infections. Toxoplasmosis is one, cryptococcosis is another one, and then you will have CMV, which is the virus, cytomegalovirus. Again, this is an opportunistic virus. And Candida, obviously, like Candida on the mouth, Candida when we do endoscopy, you can have Candida on the esophagus, and then disseminated non-tuberculous mycobacterium. Whenever you have an atypical tuberculosis, think about HIV/AIDS. If you have an unexplained lymphadenopathy, if you have unexplained fever, if you have chronic diarrhea for more than 1 month without the culture is negative, it's not bacillary, obviously, for 1 month or more, it can be HIV. Okay, and then we have extrapulmonary tuberculosis. Extrapulmonary meaning in the lymph nodes. Uh, the lymph nodes can be enlarged with HIV, but you can have tuberculosis in the lymph nodes. You can have tuberculosis as tuberculous meningitis, and then you can have tuberculosis somewhere else. Okay, and then lymphomas and cancer. This is what we think is the severe form, especially when you have Kaposi sarcoma. Whenever you have a diagnosis of Kaposi, then I think there is certain HIV there. Then, as I said, we are now in stage 4 with the encephalopathy, and then recurrent severe bacterial pneumonia, symptoms of cardiomyopathy. So it is a disease, a virus, which can affect all the systems. So the last indication, the last advice as clinicians, you have to be aware of this disease. It is the disease of the century. It is there everywhere. There is a very important asymptomatic period when you have to diagnose the disease. The symptoms are so varied that we have to suspect HIV. And now the test is very easy, very cheap. okay? And it has to be done in every case you suspect that there is immune suppression. If you suspect immune suppression, then you have to do the HIV test. Okay, the problem is there is a gap between the virus, contracting the virus, and the appearance of the test. This is what we call a window. Patients may have the virus, but the test may still be negative. May still be negative. This is why if it is negative on one occasion, then you have to repeat it in another occasion. So there is a gap. And this gap is important in the diagnosis and in the epidemiology of the disease. Lastly, I would like you to remember the three enzymes which are the basis of our drugs, which we will talk about it next lecture. And these are the cryptase, transcriptase, reverse transcriptase, and then the protease and the integrase. These are the enzymes which scientists have identified to be attacked. So we create inhibitors. We create inhibitors for these enzymes. And if you block the enzyme, because the enzymes are the livelihood of the virus to multiply, okay, and to attack the human cell. So if you inhibit these enzymes, you will have a drug. Now we have a multitude of drugs which are available, which are very safe, and which are distributed in many countries free of charge. However, for fear of resistance and for increase of potency, the drugs are combined. So ART is now combined 2 or 3 drugs which act in different enzymes. If you have an enzyme which is in the transcriptase, reverse transcriptase, and you have one in the protease, all right, and then you have one in integrase, then these are put together. They will hit the virus at different points, weaken the virus. And this helps in prevention of resistance. This is the method which is used to reduce resistance in other diseases like tuberculosis. We use multiple drugs, 3 or 4 drugs, to prevent or delay the appearance of resistance. Okay, and malaria again is as an example is ACT, which is artemisinin combined therapy. Again, this is one which becomes the drug becomes more effective in combination and has less chance to show resistance. So with that, I think the last message is precaution. For youngsters, they have to exercise precaution, okay, and use the preventive methods. Secondly, as a doctor, you have to think about HIV, okay, whenever you have some symptoms which are unusual, like candidiasis of the whole mouth. We diagnose HIV by endoscopy. In the endoscope, we saw candidiasis of esophagus. So be aware of the disease, okay? If you have repeated infections or repeated, uncontrolled infections, repeated abscesses, all right? This is again something you have to think of actually. So it really needs some clinical acumen to be aware of the HIV, and many of them, because we want to catch these patients very early, to give them ART to prevent further spread of the disease. Okay, with that, I think we will conclude that this is a story of success for science. A story of success for science. And that is it's a new disease. It appeared very early in the 1980s, but very soon people realized that this is a viral disease, and in less than 5 years, then the drug was available. I would just like to remind you there are two HIV viruses, what we call HIV-1 and HIV-2. If you just remember one, then you will do very well because HIV-1 is in 99% of the epidemic globally is HIV-1. HIV-2 is being reported from West Africa, and HIV-2 shares 50% of the genetics of HIV-1, but it is less virulent, it is less transmissible, and causes less disease. So concentrate on the HIV-1, which is the global epidemic of HIV/AIDS. With that, I would like to thank you very much for being with me this morning. Thank you.